Thank you for the opportunity. Give it to me, present my lecture here. Okay. So good morning. We are going to talk about the management of spine tumors, mainly metastatic. I'm going to start off with some cases. This is an elderly male with metastatic esophageal cancer to the spine, presented 2 weeks after mild trauma with neck pain. You can see there is fracture at the base of C2 and the lytic lesion in C3. What should we do? Put him in a collar, halo, surgery. What kind? Should we biopsy it? We opted for a collar, but the patient didn't tolerate it. Now what? Should we fuse his head to the neck? He's having terrible neck pain. We decided to do something out of the ordinary for him. We wanted to save him from a big fusion surgery. We performed the first stereotactic CT image guided combined to biplanar fluoroscopy transoral C2 vertebroplasty. You can see the needle in the mouth of the patient and the navigation mask on his face. The cement fills up C2 and the patient's neck pain resolves completely. 2 days later, his lytic C3 vertebra fractured when he moved from one bed to another. What should we do now? Is it time to finally perform a big fusions procedure? The patient has severe neck pain. We performed 2 additional vertebroplasties in C3 and 4. The neck pain resolved completely. Patient selection is very important. It's much harder not to do the surgery than doing surgery when you see cord compression. Spinal oncology neurosurgeons should think about their patients from the perspective of an oncologist. See the patient as a whole and not just the cord compression, and I'm the neurosurgeon that needs to decompress. This is a patient with no cancer history, has 2 months of neck pain and intermittent numbness and tingling in hands and fingers. His motor exam is 5 out of 5. You can see severe cord compression from a lesion which is both epi and subdural. What should we do? Decompress emergently, electively, biopsy first? Let's imagine that he presents with some weakness. Now what? Should we decompress, biopsy? When to do the surgery? Should we start steroids? These are all questions that me as a spinal oncology neurosurgeon must think about while everybody around you is asking for answers. The ER, medical and radiation oncologist, the patient and his family. The patient went to an outside facility, then they performed the laminectomy, removed the tumor, opened the dura, didn't close it well, and came to us suffering from a severe positional headache due to a large pseudomeningocell and methotrexate toxicity due to its accumulation in the CSF. The pathology was a B-cell lymphoma. So now the patient needs to hold his chemotherapy, is having methotrexate toxicity, and needs to undergo another surgery to close the leak, have a lumbar drain for 15 days and not addressing his new lymphoma diagnosis. Could have we avoided it? The patient was almost neurointact. We could have done a biopsy preoperatively, diagnosed the lymphoma and treat him non-operatively. If you do surgery, you did not have to open the dura if you send frozen specimen. I'm just trying to show you why spinal oncology neurosurgeons have to think more like an oncologist and not always doing the obvious, decompressing the cord. This is a 58-year-old male, comes in with 12 hours of paraplegia, underwent emergent CT which showed this huge lesion in his chest wall and entering his spinal canal. We saw a large lesion in the scout image on the kidney. The patient did not tolerate the rest of the MRI. You can see there are large blood vessels in the tumor. What should we do now? Rush to surgery? Anything else before surgery? What to expect from an RCC MET? Is it the same as a breast cancer MET? Embolization of the tumor is very important. RCC METs are notoriously bloody. Even with embolization, the patient blood loss was 8 liters and had a 14-hour surgery. You can see the 2-lever corpectomy and cage insertion. On the bottom left, you can see the postoperative MRI. You can't see a lot, right? Many artifacts. How can we follow for recurrence? We'll talk about it later. Now something that requires a completely different approach. This is a 52-year-old female, suffers from back pain and left lower extremity radiculopathy. Biopsy revealed the chondrosarcoma. This is the lesion. What should we do now? That's not a metastatic lesion. This is a primary bone tumor. Potentially, we can cure the patient. This patient requires an en bloc vertebrectomy. We start by performing a laminectomy. This is the lamina removed in one piece, putting screws and rods, and then going to the front and removing the vertebral body in one piece. That's the vertebral body with the lesion. So before we are talking about the actual decision-making process, we will talk about the goals of therapy. In metastatic disease, the goals are largely palliative. They have a systemic disease which has to be controlled with systemic therapy, and we are talking about a focal problem in their spine. We want to improve or at least maintain neurologic function through spinal cord decompression, either with surgery, radiotherapy, or systemic therapy. Stabilize an unstable spine and provide pain control will improve the quality of life. Finally, it's local tumor control, making sure after we perform surgery, the tumor is not coming back anytime soon, and we do that by some kind of radiation therapy. We have plenty of options to treat these patients, and the three broad categories are systemic therapy, radiation therapy, and surgery. Systemic therapy is evolving every day, and there are new targeted therapies that are really changing survival in some patients. Radiation therapy has evolved over several decades. We still offer conventional radiation therapy to certain patients who we think are going to respond to conventional radiation, but we can also offer stereotactic therapy. From surgical point of view, we have the percutaneous cement augmentation for compression fractures causing mechanical pain only, and block surgery for primary bone tumors or occasionally oligometastatic disease. Intralesional surgery is when you go into the tumor with instruments and debulk it, and it's mainly done for metastatic disease, where it's called separation surgery. This all can be done by a minimally invasive oncological spine surgery approach called MIOS, or through the traditional open approach. There are 18,000 new cases of spinal metastases a year. In the famous Pachel study, where we actually looked at the compressive surgery plus RT versus RT alone for patients presenting with spinal cord compression from metastatic disease, the primary endpoint was the ability to walk after treatment. In every criteria measured, the patients who received surgery plus RT did better than the patients who received the radiotherapy alone. Now we are able to approach the spine from a variety of trajectories and put it back together after we're done. This is a 4-level vertebrectomy for breast cancer met. A surgery we were not able to do in the past is now possible. It's hard to decide who will benefit from surgery. There are many classification systems described for that. This is what goes around in a surgeon's brain when he needs to decide about surgery or not. Neurosurgeons and radiation oncologists improved a lot in their collaboration in planning the radiation and decision about the best treatment plan for the patient. Conventional radiotherapy is not used that often anymore. SRT is really a game changer in the treatment of spinal metastases. We don't have to radiate all the field and the organs in the way of radiation. Radio-resistant tumors suddenly became radiosensitive. SRT is limited in the case of spinal cord compression. In order to hit the tumor with high dose, we need to have space between the cord and the tumor. Here the neurosurgeons come into the game. During my fellowship, I took part in the study done at the Ohio State University. It's currently under review about postoperative SBRT for spinal metastases. We analyzed local control, progression-free survival, overall survival, and toxicity. The most common regimen was 27 gray in 3 fractions. Most of the patients underwent vertebrectomy in the thoracic spine, were embolized. Mostly more than 2 levels were involved, and the RT extent was circumferential. We saw that performing SRS less than 40 days after surgery improved the 1-year local control from 75 to 95%, and also that preoperative embolization improved local control. RCC had the best local control. This is a meta-analysis of recent papers about SRS showing 88% of symptom control and 87% of local control. Post-SRS compression fracture is a known complication. We can perform prophylactic vertebroplasties on some occasions, although I'm not a big fan of these. Factors shown to contribute for developing fractures are osteolytic tumors, significant involvement of the vertebral body, pre-SRT fracture, and to some point the dose per fraction. We can safely deliver SRT following conventional radiotherapy with no increased incidence of post-radiation toxicity. So let's try and put together how do we evaluate the patient. How do we make these decisions, and how do we integrate all the possibilities, the systemic burden of the disease, the various radiation and surgical options? Is the NOS paradigm. Is the 4 things that we think about every time we see a patient with spinal metastases. The extent of the epidural disease is important in deciding whether the patient needs some kind of surgery or not. Mostly grades 1C, 2, and 3 need surgical intervention, whether separation surgery or vertebrectomy, unless it's a very radiosensitive tumor without instability or neurological compromise. Clearly, radiation won't fix this problem. So we had to perform a vertebrectomy. The oncologic looks at the primary tumor histology and trying to predict how responsive the tumor is going to be to therapy, which leads us to the next important factor. We need to establish a diagnosis. We need to know what we are treating. What is it? A MET, a primary tumor, infection, pseudoprogression? We need to get a biopsy. All these factors on the list are determined by the tumor histology, and we should tailor the surgical and non-surgical approach based on that. What is it? A chordoma? Does it need an en bloc surgery? That's an ependymoma that requires a totally different approach. You also would like to know if it's a bloody tumor or not. Surgery for RCC is different than surgery for a breast met. There are several options to obtain a biopsy. One very important thing, always think about the tract. Can you resect the biopsy tract? On the right, biopsy for a chordoma. The easiest way is to go transrectal, but then how you resect it. On the left, another chordoma. Should we go through the mouth? Can we resect it? Just an example of tract resection. If we put the neurologic and oncologic together, this is the plot that we get. Any patient with a radiosensitive tumor, regardless of the degree of epidural extension or cord compression, unless they are neurologically deteriorating in front of your eyes, can safely undergo conventional radiation. On the other hand, patients with low-grade ESCC with radio-resistant tumors will not respond well to conventional radiation, and these will require SRS for tumor control. The patients with high-grade ESCC and radio-resistant histology will need most likely separation surgery followed by SRS. The goal is to reduce the risk of radiating the neural structures by creating a space. Not every tumor type is allowing us to perform separation surgery, as I will explain later. Then we assess mechanical instability with the spinal instability neoplastic score. And this is a separate indication for surgery because no matter how sensitive is the tumor to radiation, if the spine is unstable, it has to be stabilized. We won't be able to do that with systemic therapy or radiation. This is SINS 13, but we don't need a SINS score to see the instability. And then we look at the patient as a whole. We need to know whether our patients can tolerate surgery. These are very sick patients. We have some scoring systems to help us evaluate the life expectancy of the patients. Some of these are outdated because they don't consider the specific response of the patient to modern chemoimmunotherapy. This is the reason we need multidisciplinary tumor boards where we discuss with medical oncology, radiation oncology, that what we are proposing is actually reasonable in the context of what this patient requires. Two famous ones are the Tobit and the Rebais-Takahashi score. They give us an estimate of life expectancy and the recommendation of treatment strategy. A common cutoff for survival to consider surgery is 3 months. Is it? Today's surgery are not like in the past where we needed huge incisions and were 15-hour long. Sometimes they are, but with today's technology, we can offer minimally invasive oncological spine surgery in MIOS to patients, let them live their life and have less pain. Why are these patients so complex? They are undergoing chemotherapy, their counts are low, they can develop bad infections. Their nutritional status is not that good. They're cachectic, their wound does not heal well. Radiation interferes as well with wound healing. It would be a disaster if a cancer patient's wound opens up. It delays chemo, radiation. That's why I partnered up with plastic surgery that will close these wounds with the help of muscle flaps to add more layers on the hardware. There's less tension on the skin, and even if the skin opens up, there are still layers covering the hardware. So what to do? What's our main tool to decide on treatment? This is where, again, our multidisciplinary team in and outside the tumor board steps in. The patients will benefit from the contribution of each of the care providers listed here. Putting the surgical options into a diagram will look like this. We have the cement augmentation for the compression fractures with mechanical pain. Separation surgery for metastatic disease, we can perform it through MIOS or the conventional open way. Or we have the corpectomy, which can be done en bloc for primary tumors or piecemeal for metastatic disease with mechanically unstable spine due to severe vertebral body involvement. Again, it can be done in the MIOS way or open way. Cement augmentation, either in the way of vertebroplasty or kyphoplasty, can help relieve the pain of vertebral compression fractures, either due to tumor or osteoporosis. I personally don't like kyphoplasty. I like when the cement fills up the vertebra and not just creating a ball of cement that lies in the vertebral body. Cited contraindications are absent posterior wall or epidural tumor. We worry from cement leakage into the canal. Look at this case. This is a disaster. Now we have to go in there and try to remove rock hard cement from the spinal canal. But we perfected the technique, and now we can inject cement into those badly broken vertebral bodies. Look at this absent posterior wall with severe mechanical pain from an L2 melanoma mat. There was complete resolution of pain. Another case of missing back wall without a leak. Epidural tumor with canal stenosis is another contraindication for cement augmentation, but again, for perfection of the technique, we can inject those as well. Look at the size of the epidural tumor. The patient was not fit for surgery and suffered from severe mechanical pain. The patient was discharged the following day. Multiple myeloma patients are ideal candidates for vertebroplasty because their bone is brittle and are not candidates for surgery and instrumentation. Frequently, the only thing we need to perform is to relieve the pressure from the spinal cord in the way of surgery. SRS is only good for a stable spine without cord compression. With separation surgery, you don't need to remove the entire tumor. Just create enough space around 2 millimeters between the tumor and the cord and leave the rest to radiosurgery. Bloody tumors like RCC may not be the best candidate for separation surgery because they will not stop bleeding till all the tumor is out. They may benefit from a gross total removal in the form of complete or partial vertebrectomy. An obligatory step in separation surgery is resecting the posterior longitudinal ligament, which is thickened and infiltrated with tumor. Resecting it aids in decompressing the cord and safely delivering SRS, thus accomplishing the goal of separation surgery. This is after separation is complete. Look at the spinal cord on the left being squashed by tumor. There's no CSF around it. On the right, the cord is decompressed. There is CSF around it. All the tissue on the periphery, its muscle flap, were dropped in by plastic surgery to heal it, to help seal a dural tear. The patient proceeded with SRS for tumor control. Segal showed us that local control probability is higher with hyperfractionation compared to hyperfractionation. Bilski's team from MSK looked at the patients who underwent separation surgery followed by SRS. These are the tumor control rates. The only thing that mattered was what dose did the tumor get. A high-dose hyperfractionated regimen has the smallest incidence of local failure as compared to a single fraction SRS or hyperfractionated low dose. This is a huge difference compared to the older publications about conventional radiation, which between 70 to 90% progression in patients who lived long enough. The artifact on imaging is a well-known problem when following for recurrence of tumors. Is there anything we can do differently in surgery? This looks better, right? I'm introducing carbon fiber instruments to my oncological surgeries here at UNMC to ease the follow-up on cancer patients and to facilitate early discovery of possible recurrences. As I mentioned before, we can perform either partial or complete vertebrectomy. Let's see briefly the key steps of performing a thoracic vertebrectomy. First, we start by placing pedicle screws. Then we perform a laminectomy. We ligate the roots in order for us to go into the vertebral body itself, to the front. We find the plane between the tumor and the cord. We perform the vertebrectomy and removing the PLL. We prepare the end plate for the insertion of the spacer, either a cement spacer or a cage. This is cement. In the lumbar spine, we have to approach the spine from the front because we don't ligate the motor nerve roots. We remove the vertebral body, thus having a complete visualization of the spinal cord, and then we insert the cage. As I showed you earlier, we can supplement the corpectomy site with either cement or a cage. Which one should we use? My fellowship, I compared both, and it's currently under review. We took the corpectomies from the last 5 years and obtained the instrument and over time pricing. We compared the difference in cord compression, operative and post-operative complications, the Cobb angle difference, and cost. There was a huge economical saving using cement, and it had a better correction of the Cobb angle. Part of the surgeries are intradural, either for MET or most commonly meningioma schwannoma. Because it is a metastatic talk, I'll not show you the common meningioma schwannoma cases, but rather the rare intradural metastasis. This is a rare case of metastatic leiomyosarcoma, intraoperative sagittal ultrasound image before and after removal of the tumor. That's the tumor on the upper part. You can see on the left the tumor pressing the cord, and it's removed on the right. A patient with breast cancer who had a dural-based metastasis. The tumor is visible on the left image. A rare case of cervical neurofibromas anterior to the spinal cord with complete removal. So in conclusion, We can restore and protect neurologic function. We can improve pain and have a significant impact on the quality of life of the patients. A multidisciplinary approach is necessary for formulating an individualized management plan, but there is no perfect algorithm. So in the end, we should realize that patients are not just an imaging test. They are not robots with predictable response to therapy. They are human beings, all have stories and wishes that complicate things so much that all classification systems and tumor board, while their input is so necessary, is at the end limited. Thank you.
Thank you, Dr. Kuza. The next